Welcome everybody. It's nice that you're joining this evening, and we're very fortunate to be joined by Alpesh Doshi from IVF London, who is a consultant embryologist and lab director and co-founder of IVF London. And we're going to be talking tonight about everything to do with fertility testing, initial consults, diagnosis, treatment options, and success rates. So we've had a huge amount of questions come in. Alpesh has got some fantastic information to share with us, as well as some videos. It will be about an hour. If you have any questions, there are two boxes, so please message in the chat so I can see them. And we will have a Q&A session at the end. So any questions, feel free to ask. Raise your hand if you'd like to speak at any time. And it's absolutely fine to be anonymous, of course, with your camera off. I'm Eloise, for those who may not know me, and I'm the founder and CEO of Fertility Help Hub. And it's a lifestyle fertility platform that encompasses everything and all the expert resources and specialists I wish I'd had access to when we were struggling before we had our donor conceived children. And I'd like to hand over to Alpesh Doshi from IVF London.
Thank you so much, Eloise, for that kind introduction, and always a pleasure to be speaking to an audience who are keen to find out more about different types of treatments, fertility treatments, and of course, what modern day fertility medicine nowadays involves. I'm a clinical embryologist, and I work mainly in the laboratory. But being a clinic founder and of course the clinic director, I have developed an interest all around fertility and of course IVF. And today's topic is going to be a very broad-ranged subject, whereby we're going to be covering everything that a couple or patient needs to know right from their first consultation or their first visit to the IVF clinic to obtaining the right treatment. Good fertility treatment always has to be individualized, and this goes right from the clinical practice to the laboratory practice as well. And hopefully in today's discussion, I'm going to be talking about how we individualize patient care. It all starts off with an initial consultation. What is covered in a consultation? A consultation starts off with taking a full medical history of the couple or the patient. And of course, in that medical history, we ascertain everything around, the man's health, female health, whether it's a male factor issue, whether it's a female factor infertility issue. It's very important in the treatment of fertility to actually do your investigations correctly. And what we really need to do in IVF is to keep the treatment very targeted to the needs of the couple. During the investigations, and of course this fact find or taking the history is extremely important because it helps your consultant build a framework around which investigations may be necessary from both a male or the female perspective. For the male, we start off with the conventional semen analysis. This typically involves looking at the sperm parameters such as the count of the sperm, the motility, the morphology or the shape of the sperm, how fast are the sperm swimming. And typically for the male, we recommend a 2 to 3 days abstinence before a semen analysis is done. We also look for some complex factors such as antibodies. Antibodies are when men produce some immune factors which can essentially attack their own sperm. And females can also produce immune factors that can essentially attack the embryo. The good thing about in men is that you can test for these antibodies in semen itself. We also would be doing a blood test for the routine sexual health screen in the male, such as chlamydia, hepatitis B, C, HIV. Same thing in females as well. We would do all the conventional virology screens. We would also do a thyroid function test to make sure that we're starting off the cycle with a good thyroid function level in terms of the TSH or the thyroid stimulating hormone. We also do some other tests which have shown to be important in the journey of conception, such as vitamin D, such as prolactin levels, and we would also combine the initial consultation with a pelvic scan to make sure that the uterus is free of any polyps or fibroids, which potentially, if present, can interfere with natural conception. So, for example, if a woman had polyps or fibroids present in the uterus, they may not need assisted conception, and the removal of those fibroids or polyps through a surgical intervention may solve the problem, and they may get pregnant naturally. So it is very, very important that we do not just place every couple on the bandwagon of IVF, because some of them may not necessarily need IVF, and hence the investigation of the couple is very, very important. We know that there are certain parameters that are not predictive of a woman's fertility potential, such as age, which is not really accurate. We all know that with age, fertility goes down and the quality and the quantity of the eggs go down too, but it's not necessarily that accurate of a predictor. Also, hormones like follicle stimulating hormone and luteinizing hormone are very time specific when tested in a menstrual cycle. So typically, if you're going to be testing for FSH and LH, those are best done between day 1 and day 4 of the cycle. However, one of the more robust hormones that can now be tested in women is called anti-Mullerian hormone, or AMH. And this can be done essentially at any point in the menstrual cycle. It's a simple blood test, and it's a quantitative measure of the woman's fertility potential, or the number of eggs that we may collect. It's not a qualitative measure, it's a quantitative measure. We would also look at the number of antral follicles present in each of the ovaries. These follicles are the resting follicles present in each of the ovary. They're called antral follicles, and they're very tiny. So it's very important that the sonographer or your consultant looks at these very carefully, because these resting follicles will give us an indication as to how many follicles you will develop in the event you are going to proceed to IVF. And also, it gives your consultant the ability to individualize your treatment by giving you the right dose of hormones. Because if you do have a lot of antral follicle counts, then the consultant may lower the dose of stimulation. On the other hand, if you have a very low ovarian reserve, such as an antral follicle count, the consultant may need to use a higher level of stimulation regime. Now, what do these images at the bottom show? These are both ultrasound images. The image on the left-hand side is a unstimulated ovary, and those little dots, black dots that you see, those are the antral follicles. On the right-hand side is the same ovary, but under the influence of hormones that we would give during an IVF cycle. And you can see that those resting follicles start growing in size, and so does the ovary. The ovary does increase in size once it's under the influence of hormones. And each of those follicles, you can see how big it becomes as the journey of stimulation goes on. Based on the ovarian reserve, we then customize the type of protocol that we can use in women in order to stimulate their ovaries to produce the eggs. Because we all know that as part of the IVF journey, we need to collect the eggs, fertilize the eggs, and then create embryos out of them. So, for example, if women have a normal ovarian reserve, such as an AMH of over 10 and an antral follicle count of over 10, then we would use a short antagonist protocol, or sometimes if women have endometriosis, then we may use a long downregulation protocol to get better quality eggs. In women with a low ovarian reserve, the stimulation really has to be very specifically targeted. For example, it has been seen that women with a low ovarian reserve may benefit from a mild stimulation approach, because giving them any higher doses will actually give you poorer quality eggs. You may not necessarily change the number of eggs, but the quality of the eggs may drop if conventional stimulation is used in women with a low ovarian reserve. And hence, what I mean by mild stimulation is to use very low doses of hormones, almost to the tune of 125 to 150 units per day. And typically in some of the clinics, they may go high as 300 units per day in women with a low ovarian reserve. I've heard of some clinics even use 450 units or 600 units as well. So some recent very interesting research and data that is coming out is classically showing much better of women with low ovarian reserve when mild stimulation is used. So apart from mild stimulation, there are many other types of protocols, such as a natural cycle or even a duo stim, whereby in one IVF cycle, we may stimulate the patient twice. So perform 2 egg collections in one cycle. So typically give 1 round of stimulation, collect the eggs, and if there's any smaller follicles still there, we would not aspirate them in the first round of an egg collection. Continue giving the patient stimulation even when they are undergoing a period, but the stimulation in the second phase will develop a second cohort of follicles. This is called duo stim. What are the typical treatments that are offered in a fertility clinic? It can range from some simple treatments and it can progress onto some quite complex treatments. So from a simple treatment perspective, it could simply be a follicle tracking cycle whereby you just attend the clinic, a couple of times. So for example, in women who have polycystic ovaries, they may want their cycle tracked to see that are they ovulating, are they releasing an egg? So a follicle tracking cycle may just typically involve scanning the patient in their natural cycle, sometimes giving them a trigger injection to force them to ovulate, and the couple can try naturally at home, okay, which we call timed sexual intercourse. In same-sex couples or single women who are planning to conceive, they can start off with some very simple treatment such as intrauterine insemination. What this involves is, again, in your natural cycle, at the right time, which is typically day 12 or day 14 of the cycle, when the follicle in your ovary is about to ovulate, we would inseminate the womb with the donor's sperm or partner's sperm. This depends on the specific status or the medical history of the couple, whether IUI is an option or not. I want to just add that you would potentially only do IUI in women who have had their fallopian tubes tested and made sure that their fallopian tubes are open and patent. If the fallopian tubes are blocked, or if one of them is blocked, then the chances of conception through intrauterine insemination is very limited. Typical success rates with an IUI cycle are in the region of 10 to 15%. So we then move on to the complex treatments such as IVF, frozen embryo transfer, pre-implantation genetic screening, pre-implantation genetic diagnosis. As I mentioned earlier, intrauterine insemination essentially is used as a treatment in either single women or same-sex couples, or in, you may always start off doing IUI in heterosexual couples whereby there is an unexplained infertility issue if the sperm count is normal. So moving on to IVF, the process all starts off with an initial consultation. If you need some implications counseling or support counseling, that is always a good thing to start off with. At IVF London, we also offer fertility coaching, which gives the couple a very good starting point at understanding the whole journey so that their expectations are managed. They also understand what's going to be happening at each visit, and as the treatment proceeds, what are the typical expectations that they will be faced with in terms of information. The semen analysis and all the investigations in the men will need to be done. In the women, all their virology will be tested. So when does the process start for women? Typically on the second day of their period. They would come to the clinic to have a baseline scan. What we're interested in checking is that the lining of the womb is very thin. It should be, because the patient is having a period, so the lining should be breaking down. But apart from that, we would also be looking at the ovaries and making sure that there is no cysts in the ovaries or there is no large follicles, and all the follicles present should be very tiny and small. That means the patient is ready to start stimulation. So what does then stimulation involve? It involves taking a daily injection of hormones in the form of FSH and LH. And this is taken as a one-shot daily injection, typically at night around 7 or 8 p.m. And this would be taken for around 10 to 14 days. And during this 10 to 14-day journey, the patient, the woman, would be attending the clinic every 2 to 3 days for an ultrasound scan and a blood test. The ultrasound scan will be showing us how the follicles are developing. How are they growing? Are they growing as expected? Do we need to change the dose of hormones in any way? So this is how closely we assess the performance during the phase of stimulation. Once the follicles are ready for the eggs to be extracted, so typically if 2 of the follicles are at least 18 millimeters in diameter, the patient will be given a final injection called the trigger injection to mature those eggs in the ovary. And 36 hours after this trigger injection, the patient will be taken into theater, given a light sedation, a deep sedation injection, so they won't really remember much. There won't be much pain involved. And with the aid of the ultrasound and a needle, a needle is passed through both sides of the vaginal wall, and the follicles are then aspirated and the eggs are collected through a transvaginal procedure. Typically, this procedure takes about 20 minutes to half an hour, depending on the number of follicles. Once all the eggs and the follicles have been drained and the eggs have been collected, those eggs are then sent into the laboratory, and that's when the embryologist starts working on it, and that's where I get involved. Before we talk further about treatments, it's important that we understand that are there risks in treatment? So one of the known risks with IVF is something called ovarian hyperstimulation syndrome, when the body goes into a bit of an overreaction mode because of the fertility hormones that you're taking. Again, modern day management of OHSS is very good, to the point that some of the drugs that we can use if we do suspect OHSS will tone down the reaction of OHSS and even the symptoms of OHSS in women. So most of these complications are managed at the clinic level and not necessarily need anything too invasive, such as an admission. There's always certain complications that are very generic and that also arise in natural conception, such as an ectopic pregnancy or even a miscarriage. So IVF doesn't sort that out. Yes, we have some more advanced techniques nowadays available in IVF that can help lower the risk of miscarriage. The aim from a clinician's perspective should also be to individualize treatment, and from the embryologist's perspective, it should also be to individualize treatment. What is the journey that is involved in the embryology lab? And I'm going to be talking a bit more about that now. And typically we start off with the eggs, and on day 0, you can see what the egg looks like. And then on day 1, you see 2 small dimples sitting in the middle of the egg, and that's normal fertilization. 1 dimple comes from the egg. And on day 2, the embryo develops into 4 cells. By day 3, it's 8 cells. And by day 5, the embryo has around 150 to 200 cells and is called a blastocyst. So embryo transfers can be done either at the cleavage stage, such as day 2 or day 3, or at the blastocyst stage. Research has shown that the best time and the best pregnancy rates are achieved when transfers are done at the blastocyst stage, provided a patient has sufficient number of embryos to choose from, so that we're transferring the best embryo, because embryology is a bit of a funnel. You may start off with 10 eggs and you will potentially reach 4 to 5 blastocysts. So why transfer anything which is not going to make it to a blastocyst? So this typical 5-day journey encounters a natural attrition from the egg to the blastocyst. And as embryologists, we are trained to be looking at these developmental patterns in embryos daily as we go along, trying to select and deselect embryos for a couple in order to transfer the best embryo which has the highest implantation potential. The embryo transfer technique is very straightforward and yet is one of the most skillful process in the IVF treatment. What do I mean by that? The uterus, again, is very sensitive when any foreign object is inserted to it. It starts contracting. It can sometimes expel the embryo. How can a team ensure that the delivery of the embryo is very, very smooth? You have to carry out the process with the utmost skill and take the time that is needed in order to deliver this embryo in its natural environment in the most atraumatic manner. There's no anesthetics involved generally. It's very straightforward. It's like a smear test. However, your consultant needs to make sure that they've looked at the cavity of the uterus, they've measured the uterus, they are going to proceed the catheter. The tube that contains the embryo is called a catheter. They are going to proceed this tube very gently through the cervix and release the embryo typically in the middle of the uterus rather than too far up. Because if they proceed the catheter any higher up near the tail end of the uterus, that can start the contractions and expel the embryo. So in summary, the embryo transfer technique is simple and yet very important. It has to be done by the right consultant with the right amount of experience. How many embryos to transfer? And of course, the aim of every IVF cycle is to give you a healthy baby, not necessarily increase your risks of a multiple pregnancy. It's a bit of an inverse relationship because when you increase the number of embryos, you may potentially increase the pregnancy rate. But in the UK, there are some very strict guidelines, and of course, the pursuit of every IVF clinic is to make sure that they transfer a single embryo in patients who are most likely to get pregnant. You can transfer up to 2 embryos in women under the age of 40, but anytime you transfer 2 embryos, you are potentially adding a layer of risk when it comes to multiple pregnancy. And multiple pregnancy has, again, its own layer of complications, such as premature delivery. Women can have preeclampsia, high blood pressure. You know, the babies can spend long time in an incubator, in a neonatal unit, etc., etc. We are trained in making sure that we try and optimize and select the best embryo and the right embryo in order to give the patient the best chance of a singleton pregnancy. So I always am of the opinion that as embryologists, we really need to develop the tools to see that if you have 2 or 3 embryos, which one is the one that is going to make it? And that's not an easy task, and hopefully I'll explain why. What happens to the other embryos that we create for you? So typically, as I said, if you have 10 eggs, we may be lucky to about 4 or 5 blastocysts. We freeze the embryos. And the good thing about freezing and the new technology around freezing is that 98% of the embryos survive fully intact. That the pregnancy rates with frozen embryos are the same as fresh embryos, if not slightly better. So in clinical practice, what we have seen that most of our patients nowadays are choosing to go for frozen embryo transfers rather than fresh, because again, it breaks the IVF cycle down into 2 very neat parts. One, which is collecting the eggs and then letting the patient have a period. And once all the hormones have washed out of the body, they will come back for a more gentler preparation to receive one of the frozen embryos back. And as I said, the pregnancy rates are fantastic, even with frozen embryo transfers. There is very little risk or no risk of ovarian hyperstimulation when you break the cycle in two parts. Just some images of the laboratory, and of course it's very important from a lab perspective to have the right kit, the right experience, even the facility, the air quality in the incubators, everything has to be top-notch because embryos are very, very sensitive. There are some parameters that really have to be looked after when working with embryos and eggs in a laboratory. So, for example, the temperature has to really be maintained, and embryos and eggs have to constantly be kept in an incubation environment which keeps the temperature of the eggs at 37, and that's very, very important. So, without again getting too technical, it's important to make sure that the eggs and embryos are looked after well in the lab. There are many such individualized treatments that can also be offered in an embryology lab, such as assisted hatching, where we make a small opening in the shell of the embryos, typically meant to improve success rates in women over the age of 40. However, I must say that some of these techniques are considered to be add-ons when it comes to an IVF treatment, and the evidence for its benefit may be very weak or mild. So again, it's important that your clinic really focuses on making sure that they're using the right approach for you rather than just throwing in extras, which will end up costing a lot of money too. There's something called IMSI, where we look at the sperm under very high magnification to look for abnormalities when it comes to the head of the sperm. If you look at this image carefully, you'll see that there's some sperm where my arrow is pointing, which have got vacuoles or air pockets. These are not considered to be good sperm. And even if it fertilizes the egg and creates an embryo, the chance of that embryo developing to a live birth are very slim. There are techniques like IMSI, whereby we would look at sperm under very high magnification to make sure that we are selecting sperm that are very clean. Now, I must add that the age-old focus has always been on eggs and the quality of the eggs and the age of the woman. But there's so much more emerging now on fertility in men, and how is their sperm parameters affecting the outcome of IVF, such as sperm DNA fragmentation. This is one of the new generation tests that is now almost routinely done in some clinics to test whether the sperm's health or the DNA damage in sperm is at a very, very minimal level. Because again, it has been seen that men with advanced age can also develop higher DNA damage in their sperm. So the focus is also now becoming quite multifactorial rather than just concentrating on the egg and the egg health. We are also now looking at a lot of parameters to do with sperm. There are certain culture media that can also kickstart fertilization, such as calcium ionophore, which again, it's not used as a routine treatment in all patients, but in selected cases whereby the fertilization rate with ICSI is poor. And I'm going to play a video here which shows how we look at various types of divisions of the embryo. So you can see that that's called a time-lapse image or a video. We have an embryoscope in the laboratory here where we are culturing your embryos. And once they're culturing in there, the good thing is they don't need to be taken out, and yet all the information that we need to have is captured by images that the camera is taking every 15 minutes and then reeling a beautiful video like that. So the embryologist is constantly looking at how the embryos are developing over the 5 days. And here we are. This is how we utilize all this information in selecting the right embryo. So there is a clock playing on the right-hand side. And again, as a trained embryologist, I know what the embryo should be doing at certain time points. So I might just pause it and see, okay, at 98 hours, the embryo should be A cavitating embryo. Which embryo is cavitating? Yes, embryo number 2 has started cavitating, whereas embryo 1 hasn't. So I prefer embryo number 2 because it's more advanced. At 104 hours, what is the embryo doing? Well, this has reached a grade 1 blastocyst already, whereas the other ones are still early. I like embryo number 2. So this is how embryologists work. They just don't look at a static image of your embryos. They are continuously assessing the development of your embryos over the 5 days at various time points so that they can select the right embryo for you. As I said, the pressure is always on the lab to select the right embryo. I move to the genetics, and I'll take another 5 minutes and then we will start the Q&A. There is phenomenal technology now available which enables us as reproductive scientists and clinicians to optimize success rates a bit further. Now, again, I say this with caution because pre-implantation genetic screening, or PGTA, is considered to be an add-on from a regulatory perspective, and it is important that we identify the right patients who will benefit from PGS, because again, it's not a cheap technology. It's quite expensive, especially if applied in a private setting. PGS, it relies on looking at the genetics of the embryos. We know for a fact that when embryos do not implant after an IVF cycle, or if they result in a miscarriage, in 90% of these cases, the problem is with the genetics. So if I tell you that if you are 40, the chance of you having an embryo that is going to make it to a baby is 1 in 10. That means if you have 10 embryos, there is 1 embryo in there that's going to make it. So which one is it? And this is what PGS does. PGS looks at the internalization or the chromosomes or the genetics of that embryo to try and find that golden embryo for you. So what does this involve when it comes to the test itself? So here we are in the laboratory. What we do is we perform an embryo biopsy or a blastocyst biopsy. So that is a blastocyst that you can see. And what I'm doing there, I'm using a laser beam to dissect some of the cells from the embryo. And I don't want you to get alarmed because this level of manipulation is pretty normal, again, in the right pair of hands, in the skilled pair of hands, because ultimately you are taking some cells away from the embryo. So you can see that I have just taken a small biopsy of the embryo. That's a small clump of cells, and the embryo itself is still very hale and hearty, nicely intact, and that embryo is going to be frozen. What then happens is we send all these clumps of cells that we have taken or biopsied from embryos to an expert genetics lab that will test the genetics of those embryos. And they'll give us a detailed report in a matter of a week or 10 days to tell us exactly which embryos are genetically healthy and which embryos are genetically faulty, so should not be transferred at all, because if those embryos are transferred, they may result in a miscarriage or a failure to implant. So we then change our focus totally on the golden embryos, which gives a much higher chance of a pregnancy. Typically, if I can say, it may add another 15 to 20% on the chances of a pregnancy. And it may reduce the miscarriage rate from almost 20% to less than 5%, simply because the embryos have been super selected. I now move on to success rates and how patients should interpret success rates. So success rates can be presented in many ways. One, it can be per treatment cycle, meaning the number of women who start off stimulation. That is a treatment cycle. So the number of pregnancies, say if 10 women started stimulation and 5 of those got pregnant, the pregnancy rate is 50%. The other parameter is per egg collection. So say, for example, not every woman who starts stimulation may end up having egg collection, because some of them may cancel because of poor response to stimulation. So, for example, if 10 women started stimulation and 9 of them had egg collection, then the pregnancy rate becomes 5 out of 9. So it's 55%. Then the third category is per embryo transfer. So say if 9 women had egg collection, 7 of them may have embryos transferred because some women may not have fertilization or may not have blastocysts formed, etc. So you may lose some of those in the process as well. So again, the denominator changes. So if 7 women are going to have embryo transfer, then the pregnancy rate becomes 5 out of 7 and it becomes 71%. So you can see how in the same cohort of 10 patients, the stats can vary from 50 to 71%. And that's when nothing has changed, but purely the denominator with which success rates are presented. The more newer way of presenting statistics, which has been also promoted by our regulators, the HFEA, is to present statistics per embryo transferred. Now, this means that if you are transferring 2 embryos in a lot of patients, but they are ending up with a singleton pregnancy, then your pregnancy rate will be lower than a clinic that is essentially transferring a single embryo in those patients and yet achieving a singleton pregnancy. So for example, if 10 women start treatment and 7 of them have transfers and 5 of them get pregnant, the pregnancy rate is 45% based on the number of embryos. So let me make this simpler. If 5 women have a double embryo transfer but a single pregnancy, that means that their pregnancy rate is per embryo transferred is 25%. But if 5 single embryo transfers result in 5 singleton pregnancies, then the pregnancy rate is 50%, simply because the denominator of the number of embryos has changed. Pregnancy rate per embryo transferred, not per embryo transfer. And it is the pregnancy rate per embryo transferred that is a true measure of success rate of a clinic, because that shows you that they have got good tools in place to select the right embryo, and everything is very robust in terms of their techniques to make sure that they will get the right number of eggs, they'll get the right number of embryos, and they will deliver the embryo in the most atraumatic way back into the uterus. The embryo transfer is all good. So the best pregnancy rate is when you get a high per embryo transfer success rate. There'll always be this blue bar, which is the pregnancy rate when someone does a positive pregnancy test. Yet when there'll be a clinical pregnancy rate, which is when we do an ultrasound scan at 7 weeks to see the fetal heart. So that is considered to be a clinical pregnancy. And finally, the clinical pregnancy rate per embryo transferred, which gives you the measure of how good the practices are. Ideally, your clinical pregnancy rate and your pregnancy rate per embryo transferred should be very, very similar. And you can see that in most of the cases it is.
Thank you. Thank you so much, Alpesh. That was just amazing and so informative, and the videos too. So if anyone has any questions as we're talking, please feel free to just put them in the chat box. I have the chat box ready. So one of the questions was, what happens at the initial appointment? You mentioned about the tests. You mentioned about your coaching, which sounds like a very, very valuable thing to have as part of the process. I didn't have that. What would you say people should expect in terms of, what they might be anticipating, whether they're fearful about it, and also the timelines that come with that?
Sure. So an initial appointment is always in the form of meeting your consultant, and it may involve some tests, not necessarily always, because sometimes GPs may already have done some tests, or couples may have already been to their GP to do some basic tests. So essentially 30 minutes is purely taking the medical history down. It's usually an hour, 45 minutes to an hour appointment. 30 minutes is spent on taking the history, and then the other 30 minutes is essentially talking about the various treatment options. If the woman needs a scan, then a quick pelvic scan will be done to look at the ovarian reserve. If she hasn't had any AMH testing done, the nurse will take the blood test for AMH. So we try and keep it quite one stop, because we want to make sure that that visit is really meaningful in trying and getting as much as we can done to assess the couple's fertility. So what I don't like doing is telling the patients that, okay, today is just a chat. You come back for a semen analysis, come back for a blood test for AMH, come back for a pelvic scan. No, we try and do this if the couple wants, of course, all on the same day. So typically the consultation can be an hour.
And is that the same as a fertility MOT then? You do it all in one go?
Yeah, fertility MOT is very similar, but it focuses more on the women, of course. But of course, for men as well, they can have the semen analysis done. But a fertility MOT looks at the AMH, looks at the antral follicle, and there's a 30-minute consultation with the consultant who will give you more a chat on the time that you have from a fertility perspective. Because generally, women who have a fertility MOT are more interested in knowing that, can they delay having a child for another year or two? But if their ovarian reserve is very low, then the consultant may well say that, hang on, either you freeze your eggs now, or you try and get pregnant now. Because if you leave it for another 2 years, your ovarian reserve may have declined further. Or if the ovarian reserve is very good, you can safely tell the couple or the lady, the woman, that yes, by all means, take your time and not take another year or two, because you have good fertility and good ovarian reserve.
Mm-hmm. Thank you. We've had a live question come in, so I'm going to jump to that quickly as we're a bit short of time. They've said, how much is Zymot used in your clinic and which areas is it used? They have poor embryo development and they're considering this, so they'd like to know about that.
So I'd like to say that I like Zymot a lot. So what is Zymot? Zymot is actually a chip that we use in the lab to super select the sperm. And the theory being that sperm in an ejaculate have a lot of damaged sperm, such as DNA fragmented sperm. So what the Zymot chip does, it super selects sperm that have got more healthy DNA or less DNA damage. So we use Zymot for all our ICSI cases if the sperm count is over 1 million. And I'd like to add, I've had phenomenal experience with Zymot, and I tend to use it for all my patients, and there is no extra cost per se unless it's prescribed. But all patients having ICSI will have Zymot as part of the treatment.
Fantastic, thank you. If anyone else has got any live questions, please ask before we run out of time. Do you do egg collection abdominally in the case of endometriosis?
That's correct. We do egg collections abdominally. It all depends on how accessible the ovaries are vaginally. So there are a lot of women who have endometriosis, but yet their ovaries are accessible vaginally. But if the ovaries are very high up, in the pelvis, then we would have to go abdominally. And again, we do abdominal egg collections quite often.
Is endometrial scratching recommended? How successful is it?
It's a very good question. Endometrial scratch used to be a thing to do, many, many years ago. And then there was a detailed study that was done by Eshrey that looked at the evidence around endometrial scratch. And disappointingly, there wasn't much evidence for endometrial scratch. So again, our take on this is that, yes, it can be done, but the evidence is very weak that it may improve success rates.
What are the success rates with unexplained infertility, which is one of the questions we had before? And are there additional tests we should look at to increase success rate?
So with unexplained infertility, always best to start off with intrauterine insemination, because it's a very simple treatment. And I don't want couples or our viewers to think that, oh, well, it's just a 10 to 15% success rate, so why even attempt it? No, I think that's not the way it should be considered. You start off with the mildest treatment, and if that doesn't work, you move on to the more complex treatments such as IVF. So I would always start off with intrauterine insemination if the sperm count is good, if the woman is young in age, if her fallopian tubes are open. Let's try the simplest way. We try a couple of cycles of IUI. If that doesn't work, then we move on to IVF. If it doesn't work with the simpler methods, then IVF should definitely offer them an over 50% chance of getting pregnant, provided the woman is under 38 years old.
Thank you for such an informative webinar. 2 questions. 1, a lot of the focus is around fertility. It's about the embryo and the lack of andrologists out there. What do you suggest for men to increase their fertility or success rate?
From a lifestyle perspective, there's a few things that can be done for men. Certainly try and make sure that they take the supplements, their diet is good, reduce alcohol, stop smoking, stop vaping, stop shisha. All that has known to damage sperm quite badly. You know, try and not have hot baths, try and minimize laptop use on your laps, etc. So all these things has known to damage sperm, and there's awareness around radiation, etc., etc. So good diets, high zinc, to try taking zinc as a supplement. All that should help.
And the second question was statistics of success rates are published on the HFEA website. There are hundreds of clinics. So is there a simpler way to compare success rates between clinics, as it can be hard to pick a clinic? They've mentioned, as such a league table for success like there are at schools.
The HFEA website is the most non-biased way, and it's all the generic, how should I say, it puts everyone in the same platform. Because individual clinics may present their websites in a way that looks rosy for them. So they may use parameters like per embryo transfer rather than per embryo transfer. Whereas the HFEA website looks at pregnancy rates per embryo transferred, per cycle started. So I think if you want to compare clinics, you're better off using the HFEA website. Having said that, our success rates are not on there yet because we're a new clinic, and the HFEA only publishes the stats after they've had 2 years worth of data. So that's going to be, that's going to be published soon, I believe in July for our clinic as well on the HFEA website.
Well, from the graph that you shared before, they look very high. Yeah. And is there anything you suggest they should prepare for an initial fertility clinic appointment, or scans or tests?
So my advice is always bring all the information that you have. When you're attending a fertility consultation, you want to make sure you get the most out of it, and that your consultant gets to know everything that he needs to know. Because if you have had an HSG, for example, to test your fallopian tubes, and you don't bring the results, then your consultant doesn't know that. So I would say that a week before your consultation, please be organized, get all your blood test results, get all your semen analysis results from your GP if you've done them.
For women, do you do a test for PCOS and endometriosis in the MOT?
For PCOS, yes, when we do an MOT, we would do a pelvic scan, which would show us the number of antral follicles, which is classically indicative of PCOS patients, and the AMH test that we would do. That would also be very high in women with PCOS. So same with endometriosis, because we'll do a pelvic scan, we'll be able to see the ovaries and the endometriosis a bit better.
And what is your protocol or view on taking progesterone after embryo transfer? They were told to stop taking progesterone when they got a positive test, and it sadly ended in a miscarriage.
No, you should never stop taking progesterone at positive pregnancy test, because the progesterone is very important for the lining of the uterus to continue developing the pregnancy. Because if the lining breaks down, that means the pregnancy is lost. So we continue progesterone up to 10 weeks of pregnancy, because it's then that we can say that the placenta takes over the production of progesterone. So we start weaning the progesterone down essentially only after the first scan, and totally stop progesterone after 10 weeks of gestation.
How can PCOS affect fertility?
PCOS can affect natural fertility. So women may find conceiving very difficult if they've got PCOS, because they are struggling to ovulate. What happens in PCOS, that all the follicles are so tiny that none of them are even maturing and releasing an egg. It's called an ovulatory PCOS. However, these women are very easy to get pregnant if they take simple medical help from a fertility clinic, such as ovulation induction, whereby we will give some tablets of clomid or clomiphene, and they will nicely develop 1 or 2 follicles, release an egg, and they may get pregnant naturally. So PCOS patients actually are the best candidates to get pregnant from assisted conception.
If anyone else has any more questions, please do contact Alpesh. You have the contact details there.